So if it's a 1 plus malaria QBC, then that means it's malaria. There's malaria, but it's not severe. It's mild. When it's a 2 plus, that means yes, there's malaria for sure, and definitely the child needs to be treated. 3 plus, 4 plus means there's a lot of malaria parasites in the blood.
Hello, viewers of Pediatrics to Go. I'm Francisca, once again, your co-host of Pediatrics to Go. And here we have Dr. Sanusi as always. She's going to be talking to us about malaria. So stay tuned and, enjoy.
Hello, everyone. Happy 2024 again.
Yes.
We're going to be talking about malaria because it's a very, very common diagnosis that we see in pediatrics. Now, we have a lot of children coming in, and when they have a fever, parents are like, oh, it's malaria, and I treated for malaria already. And we say, Mom, Dad, fever is not necessarily malaria. So most of the children that come in with fever into our facility, we actually check for malaria. And guess what? More than 70% of them come back malaria negative. More than 70%. And the reason is a lot of children have viral infections. So malaria is not the commonest reason we see fevers, at least in our population, in our practice. We see a lot of viral infections, and we see malaria very rarely, especially now that there's a lot of people fumigating their compounds. There's a lot of awareness about the life cycle of the mosquito. And generally, malaria is not the number one reason that children have fever in Nigeria as of right now in our practice. So when a child comes in and we check for malaria, we also check CBC or full blood count just to see if the white count is elevated or not, and to see if the malaria is positive. If the malaria, we can do an RDT, which is the rapid diagnostic test for malaria. And if that comes back positive, then we do the QBC, where we take the blood and we look under a microscope and we actually count how many malaria parasites are there per high power field. So there's different ways of giving the amount of malaria. We have 1 plus, 2 plus, 3 plus, 4 plus. When you have 1 plus, it means there's hardly any, there's actually a number that we use, but that's beyond the scope of this talk. So if it's a 1 plus malaria on QBC, then that means it's malaria. There's malaria, but it's not severe. It's mild. When it's a 2 plus, that means yes, there's malaria for sure, and definitely the child needs to be treated. 3 plus, 4 plus means there's a lot of malaria parasites in the blood, and those children might have a longer course of illness. They can also have more symptoms, higher fever, and they can be sick, quite sick. So you want to pay attention to the pluses on the QBC test, especially for a child who's positive on the rapid diagnostic test. Now, once a doctor diagnoses that a child has malaria, then we recommend treatment. And the treatment of malaria has come a long way. In the past, we used to use quinine, which had a lot of side effects.
I was allergic to quinine.
There you go. Then we're using chloroquine, which was very common in the past.
No, I think it's chloroquine. Yeah,
yes, there's chloroquine, there's quinine.
Okay, it was chloroquine I was allergic to.
Yes. So, and then over time, we came into the artemether lumefantrine treatment. Then you also have the IV versions of like Palutha and all that, all the IV versions for children who are not able to eat and who are extremely sick. So what we always recommend, anytime you go to see a doctor or you go do blood work, check for malaria, especially if your child is sick. If the malaria test is negative, we actually do not treat unless we're suspicious that, well, the symptoms look like malaria and it doesn't hurt to treat. Now, when children get malaria and they are treated, they should get better. The treatment usually is for 3 days, and the dose usually comes on the packet. Whatever medicine you're getting for malaria treatment, you want to just make sure that it's under the care of a physician. I know you can go to a pharmacy and go pick up antimalarials, but if you're going to give antimalarials, first of all, you have to make sure that your test is positive or negative. If it's positive, then go ahead and get treated. And usually, once you get treated for malaria, your symptoms should start getting better within 72 hours. So if you're not getting better, you've taken your 3 days of antimalarials and the illness is just getting worse, you want to definitely follow up with your doctor. Now, a lot of people travel from different parts of the world to Nigeria, and there's that common question that I get asked in America all the time. It's like, what's the prophylaxis to take. What is the preventative medicine to take for malaria since I'm going to Nigeria? And there's two recommendations in the US. I know it's in different parts of the world, there's different recommendations. And the recommendations for Nigeria are based on the Center for Disease Control guidelines on what malaria parasite is prominent in the country. Now, you go to different countries of the world, you can have, Plasmodium is the main parasite. You have Plasmodium falciparum, which is the commonest. There's different types of Plasmodium, but based on the commonest malaria parasite here in Nigeria, it's the Plasmodium falciparum.
I think it's 90% prevalence in Nigeria, in Africa.
Our specialist for Nigeria has spoken.
No, I did it in parasitology class.
Yes, she did it in parasitology class, so she's very current. How many? What's the percentage in Nigeria?
I think 90. It's really high in Africa.
So you have Plasmodium ovale,
Plasmodium malaria,
Plasmodium, and there's one more. What's the
Vivax?
Plasmodium vivax.
Vivax.
Is there any more? Did I miss any other?
I think there
There's
are
four types. There's four types.
Vivax, malaria, falciparum is the most common.
So, for instance, if you're going to the West Indies, the Caribbean, there's not actually a high incidence of malaria there. But if you're going to different parts of the world where there's malaria, for Nigeria, if you're coming here from the US, usually they would recommend either mefloquine, depending on the age of the child, or Malaron. Those are the two. And many times people call me and say, I'm going to Nigeria, what should I do? So we're like, okay, go to the CDC. Because there's restrictions on prescriptions, especially for adults, when they come see me in my office, I still go to CDC and check what the recommendations are, and then we can give them prescriptions for either mefloquine or Malaron, and then the insurances usually pay for it. So we always recommend if you're coming to Nigeria and you need the malaria prophylaxis, you want to start a month before you travel. Oh. So for instance, the mefloquine is every week. So you start four weeks before you travel, and then the Malaron is every day. So we usually recommend start at least a month before you travel. Some people can't because they are probably traveling 2 weeks before they get on the plane and they're reaching out to get anti-malarials. But start it as soon as you can. When you get to Nigeria, keep taking it. And when you get back to the US, usually you're supposed to continue for about 1 or 2 weeks after you get back. And people, when they come to Nigeria and they get back and they have a fever, they are worried that they might have malaria. And what we usually recommend is, take some artemether-lumefantrine when you're going back, just in case. But generally, if most people, when they get back to the US and they've had a fever, when they go and check for malaria, it's usually negative. But we also say follow up with your physician in the US so that they can check to make sure that the malaria was negative.
So is there any relationship between individuals with the AA genotype and always having prevalent malaria infections? Because I think
you know the answer to that.
I do.
Yeah. Well, malaria is actually when you have AS genotype, you usually don't get malaria.
Yes.
Yeah.
Really?
So, yeah. It's not very common because generally they say that malaria likes it doesn't like the sickle cell gene. So sometimes when you're AS, you could have some sickle cells in your body, but that's actually protective against malaria.
Oh wow.
So most AS patients don't get malaria easily or as quickly as
AA.
Someone who has a genotype of AA. Yes. But it's still good to always, when you're going out in the evening, especially in Nigeria, wear your insect repellent. If you're going to if you're going to a place where there might be a lot of mosquitoes. But in Lagos, I don't see a lot of malaria. Well, we don't see a lot in our office, and we don't see a lot of mosquitoes generally when we go to different places. I guess because I'm older and the places that we go to are fumigated most of the time.
But in the rural area, it's
still very prevalent, yes. Yeah. So please go and get a test for malaria before you start taking antimalarials. The reason is we always tell everyone that's taking antimalarials, these antimalarials, they can affect your kidney and your liver, especially if you have G6PD, which is an abnormality of the red blood cells. So if you have G6PD and you take anything containing sulfur like your Fancida, that can make your child go into acute kidney or liver failure. So you want to be very careful. Don't just give antimalarials just because these are very potent medicines and they can affect your liver and your kidneys, especially if you take it at the wrong dose or the wrong age, or you have abnormality of your red blood cells. But that's malaria really in a nutshell. And thank you very much for listening. And
Thank you. We'll catch you all next time.
Take care.
All right. Bye.
Bye.